Hello everyone, my name is Dr. Obin from home and welcome to my YouTube channel. This is the first time I'm showing my face, and this video will begin a video series on how to perform clinical examinations of the various organ systems using the OSCE format. And so we are going to demonstrate how to examine the cardiovascular system in this video using a healthy patient. The video will be in two folds or two sessions. One, I will go through the steps of how to examine the cardiovascular system, explain certain rationales behind the things we do. Then the second video will be a demonstration. I will present as a candidate writing an exam, and then I will examine the patient as though I were writing an exam. Thank you. Walk through a door, and then when you get into the room, the first thing you do is to greet your superiors, and usually there will be an instruction written on a plain paper pasted on the wall. And in this case, the instruction is examine this patient's cardiovascular system. So, right after the bell is rung to begin, you just move to your examiners, look at them and tell them that you want to wash your hands. So if you have a hand sanitizer, you quickly demonstrate that you are ensuring infection prevention and control. Then you come to the patient's right side. You do not speak to the patient standing on his left side, always the right side. And then what you want to do here is to introduce yourself to the patient and then state the purpose for which you have come to the patient, and then gain the patient's trust and confidence in you. And after that, seek consent or permission. And so for the OSCE exam, you have to speak audibly and then give explicit instructions. And so I'm going to begin by introducing myself as a candidate. And so I begin this way. Good morning, sir. My name is Kofi Amwako. I am a foreign trained medical student who has been asked by my superiors to examine you. This will involve me looking at you. Sometimes I'll be touching certain parts of your body, and if necessary, I'll be listening to certain parts of your body with a stethoscope. It is not going to be a painful procedure. It may be uncomfortable, but please feel free to stop me at any point if you feel the need to do so. Do I have your permission, please, sir? Yes. So once the patient gives the go ahead to, examine him, after he sought for permission, the next thing is exposure. And so for the cardiovascular exam, the patient should be exposed like how this friend of mine has exposed himself already before I even got there. And so the chest should be exposed, and then for the lower extremity, you should expose the patient's lower extremity to the level of about the middle section of the thigh. And so for an ideal patient, the patient should be in boxer shorts. But this is okay for the exam. Now, assuming this patient was in shirt or in a singlet, and then you wish to expose the patient, you give the patient a clear instruction that said, can you kindly take off your shirt? And if he's struggling, you do not touch the patient. You speak to him courteously and say, please, if you wouldn't mind, can I help you take off your shirt? So you don't just go and then no, because there is marks also for courteousness or courtesy. Yes, so after exposure, then the next thing is correct position. And so permission and introduction, exposure of the patient, and then correct position of the patient. Now when you are doing a cardiovascular exam, the bed has two parts. The bed has a head end of the bed, as you can see, and then a foot end of the bed. So usually for a cardiovascular exam, the patient should be in a position in which the head end of the bed is at 45 degrees to the horizontal. So this is the horizontal. So the head end of the bed should be elevated to 45 degrees to the horizontal. And so to do that, there are certain levers at the foot end of the bed, or levers if you wish. So you can see these levers. They are used to adjust the position of the bed. Okay, so I want to adjust the head end of the bed. And so I move the levers this way. And so as you can see, I think this is more than 45. Yes, so you can see the head end of the bed is at 45 degrees to the horizontal. So permission and then introduction, consent, correct exposure, correct position. Now I should mention that for the exposure, if you have a female patient, remember we said that they should be exposed, the chest should be exposed. But if you have a female patient, what you want to do is to cover the area of the breast up, keep it covered until you get to the chest. If you want to examine, you gently or you ask the female to take off that part you've covered and examine. Right after examination, you cover the chest so that you don't expose her too much. That will really make her gain your trust and then will increase her confidence in you. So after permission, consent sought, after correct exposure, after correct position, the next thing to do is to come and stand at the foot end of the bed. Now at the foot end of the bed, you are observing the patient and then the patient's surroundings. So the patient and his surroundings. So you are going to begin with the patient. What are you observing on the patient? So the first thing you want to notice, does the patient look well or unwell? If the patient looks unwell, again you want to know if the patient looks chronically unwell or acutely unwell. And so for signs of chronic illness or a patient who is chronically unwell, you may find out that the patient has a general wasting, general cachexia. It is a sign of chronic unwellness. Sometimes, in addition, you can find or you may find prominent bony rib cage, prominent clavicles. You may find out that the cheekbone, known as a zygoma, is also prominent, and then this is where the temporalis muscle is. You may find that it is also wasted, and all these are signs of chronic illness. Apart from that, the patient may look depressed, the mood may be depressed. All these are signs of chronic unwellness. Then we have acute unwellness. The patient is okay, well built, but may show signs that he's in pain or he's in distress. And so the first thing we want to know, does the patient look well or unwell? And if unwell, is he chronically unwell or acutely unwell? Then the next thing about the patient again is to observe for any signs of respiratory distress. And so for the respiratory distress, you want to look at the nose, this part of the nose. This is the nose of our patient. Let me use a pen for that. Okay, so this is my pen touch. This is the nose of our patient. So we have the wings of the nose. In Latin, wings is ala. Okay, so you see that the ala will be flaring. Can you try flaring your ala? Again, again, again. So if the patient is in slowly, like smoothly, slowly, good. Again. If the patient is in distress, you may find out the ala are actually flaring. Can you flare? So that is the ala flaring. So if you see flaring of the ala nasi, it is a sign of respiratory distress. Then apart from that, the patient may be using the accessory muscles of breathing for his breathing. Okay, so usually when you are breathing, we shouldn't be seeing you use some muscles like the sternocleidomastoid muscle. But you realize that when the patient is breathing, he's using those muscles, sternocleidomastoid, serratus anterior here, and sometimes the scalene muscle. So all these are accessory muscles of breathing, I wanted to say. And so, apart from that, you may find that this part of the neck, the suprasternal region, is receding. That is called the suprasternal recession. And then this patient doesn't have a prominent, he doesn't have prominent intercostal spaces. Why? Because he's not chronically unwell. But if he were in respiratory distress, you see intercostal recessions. Okay, and then you may see some subcostal recessions as well. Then other things that will point out to respiratory distress again include cyanosis. So there may be darkening or bluish discoloration of the lips. And then the patient may be on oxygen via any oxygen delivery device, like a nose mask or a nasal prong, I wanted to say, face mask or non-rebreather mask with an oxygen connected. So all these are signs of respiratory distress. And so, to summarize, we need to know the patient's state, whether he's unwell or well. Then we need to assess whether the patient has any signs of respiratory distress. Then, after doing that, we want to check the patient. Are there any medical interventions by way of devices which have been connected to the patient as a way of intervention? So you want to note whether there are any cannulae, okay, where they are. So maybe the patient has an IV cannula on the dorsum of the right hand. You want to note that. If the patient has a chest tube, you need to comment on that the the patient has a right-sided chest tube which is draining maybe a serous fluid. You need to check the chest, what is contained in the chest tube. If the patient has a urethral catheter, you want to mention that. And if the patient has any central lines, all these you need to check that. Okay, so that's on the patient. Then, still at the foot end of the bed, so standing there. Standing at the foot end of the bed, you are done with the patient. Now you go to the patient's surroundings. So for the surroundings, for cardiovascular exam, again, you want to see whether there are any oxygen cylinders there. You want to check the patient's drug table, if there are any things to suggest what the patient is being treated for. So are there any GTN sprays, glycerol trinitrate, which is used for the acute relief of anginal episodes. So once you are done with those things, then you can quickly observe for an obvious pedal edema or an obvious abdominal swelling. So all these should be done at the foot end of the bed. Very good. And so right after doing what you have to do at the foot end of the bed, again, you walk to the patient's right side. And then when you get there, you don't just do this. Always remember to give explicit and clear instructions. And so quickly, sir, can you please give me your hand? The patient will give you his hand. And you are looking for hand signs that points to cardiovascular disease, or that may point to cardiovascular disease. So one of the first things you want to do is to check for palmar power. So you compare your palms to the patient's palm. Whatever you do on the left, on the right, you do on the left. So after you are done with palmar power, then one of the things you have to do is to check for clubbing. And as you know, we have 5 stages of clubbing. Starting from stage 5, you have hypertrophic osteoarthropathy. Then stage 4, you have the drumstick appearance or the bulbous enlargement of the pulp of the fingers. And stage 3, you have the increased convexity of the nail itself in both the horizontal and then the longitudinal direction. Then stage 2 is the loss of the Lovibond's angle. We'll explain these in other videos. This one I'm just going through the steps. Then the first stage is increased flatulence or sponginess of the nail bed, if you will, or the nail fold. So I start by checking for the 5th stage of clubbing. That stage can be seen just by inspection. I can't see that here, and then I can't see that here. So I move to, so the 5th and 4th stage can actually be checked at the same time. Okay, I can't see the hypertrophic osteoarthropathy. I can't see the bulbous enlargement of the distal part of the finger. So that is okay. Stage 5, stage 4 out. Then stage 3 is to check for the increased convexity of the nails in the horizontal and then longitudinal direction. So what I do is I bend and then check the increased convexity at eye level. There is none like that. This is in the longitudinal direction, and then I check in the horizontal direction. I do same for this place. Check at eye level and then at eye level. So always you have to bend down at eye level to check for that. Then we come to, he hasn't got that, so we come to stage 2. So for stage 2, we are looking for the Shamrock's window, or the diamond-shaped space or gap which is created when the thumbs are opposed to each other. So you tell the patient, please, can you oppose your thumbs like this for me? And then do same for the end. Then you look for this gap, the gap there. So the gap there, that diamond-shaped gap is the Shamrock's window and the Lovibond's angle. Okay, so the Longbon's angle is actually the angle between the nail base and then the nail itself. But the obliteration of that is called the Shamrock's sign, or you can say that there is loss of Longbon's angle. Then for stage 1, you look for flatulence. So the skill there is that you put the volar surface of your thumb, the two thumbs, underneath the finger you are checking for the clavin like this, and then you'll be palpating the nail base or the nail fold at the base, okay? Looking for increased fluctuancy. So whatever you do here, you do on the left as well. So that is for clavin. Then here again, you can check for peripheral cyanosis. Check for peripheral cyanosis, bluish discoloration of the extremities. Check for peripheral cyanosis like that. Thank you. Then you can also check for capillary refill time here. So you press on the nail bed and count for about 5 seconds, and then release it. And then it should refill in less than 3 seconds. So 2 seconds or less. It shouldn't be more than 3 seconds. If it is that way, then there is a sluggish refill. Then you can check for stigmata of infective endocarditis. There are a number of them. We have the splinter hemorrhages, the Woow lesions, Osler's nodes, and even clavin itself is a stigmata, it's a peripheral stigmata of infective endocarditis. So you check for splinter hemorrhages, bleeding, small bleeding points in the fingernails. This patient obviously has not got one. Check for splinter hemorrhages here, none. Then you turn to the volar part of, or the palmar surface of the hand. You are looking for Osler's nodes, which are painful raised lesions. May also indicate infective endocarditis. Then you have Woow lesions. Woow lesions are not painful, and then they are not raised. So they are patches in the palmar surface that can also signify infective endocarditis. Here you can also check for xanthomata. Those are fatty deposits in the palm, or sometimes they can be found in the knuckles. Okay. Then you can check for nicotine stains in between the webs of the index finger and the middle finger, or you can check them on the pulp of the fingers, because people smoke like this. So there can be tar stain or nicotine stain here, or they can smoke like this, so there can be tar stains here. Now, smoking is a risk factor, it's a cardiovascular risk factor, so you need to assess it on examination. Dyslipidemia, which can manifest as xanthomas, like I said, it's a risk factor for cardiovascular disease, so you need to assess that. Then the capillary refill time measures the tissue perfusion. Okay, so you need to assess that. So once you are done with this, then you come to the pulse, the radial pulse. For the radial pulse, you are looking for its rate, you are looking for the rhythm, you are looking for the volume, you are looking for whether the arterial wall there is palpable, and you are looking for whether or not the radial pulse there is collapsing. If it's collapsing, it may indicate aortic regurgitation, as some of you may know. And so to palpate for the rate, the technique is that the volar part of the interphalangeal joint of the thumb should hold the wrist, join this way, and then 3 of your fingers, 1, 2, 3, the index middle ring should do the palpation. So you just palpate it, and in doing that, you need to count the rate, and then at the same time assess its rhythm, the rhythm of the impulse, the radial impulse. Find out if it is regular or irregular, and if it is irregular, you need to find out if it is regularly irregular or irregularly irregular. Now, for the rate, what most books teach is that you need to count for about 15 seconds, and if you deem the 15-second count regular, you can stop there and then multiply by 4, and then get your rate in 60 seconds. But I am not an authority in medicine, no way, but I would recommend that you palpate for a minute, because sometimes if the radial pulse is irregularly irregular, you may find it in the first 15 seconds or in the last 15 seconds of the 1 minute. So because you don't want to miss any irregularity of the pulse, you need to palpate it. You need to spend time here, okay, and then palpate the rate in a minute. Whilst doing that, you want to know whether the rhythm is regular or irregular. You see, a regular rhythm is one in which the next impulse can be predicted. So if you hear boom, 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 means that you can predict when the next one will come. Boom. That is a regular rate or a regular rhythm, I wanted to say. But if it is irregular, you can't predict when the next impulse will come. But the irregular rhythm can be regular or irregularly irregular. So we have a regularly irregular rhythm and an irregularly irregular rhythm. And so for regularly irregular, sometimes in patients less than 40, I think, yes, less than 40, young patients, sometimes the rate, okay, of the radial pulse or of the heartbeat varies with the phases of respiration. Okay, during inspiration, the heart beats fast, and then during expiration, the heart beats slowly a bit. And so you see that the rhythmicity of that pulse varies when the patient is in different phases of the respiratory cycle. And that kind of arrhythmia, regularly irregular, something like this: boom, 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 boom. So you realize that although it is irregular, you can predict a cycle. So that's a regularly irregular rhythm. And that is called sinus arrhythmia. Okay, it varies with the various phases of respiration. But if you have an irregularly irregular rhythm, it sounds something like this: boom, 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 boom. So you can't predict when the next one will come, and it's irregularly irregular. And as many of us may know, one of the main differentials that is queried and then examined on in exam is atrial fibrillation. And so you need to really pay attention to the rhythm. And the volume, you want to know whether the volume is reduced or it's of full volume or it is bounded to, it hits you too hard. And then this one, I don't think there's a formula for it. If you've been examining normal patients, you know how a good volume feels, you know how a reduced volume feels, and then you know how a bounded pulse feels. Okay, so you need to be mindful of the volume. Then the next, after you've done the rate, rhythm, and then the volume, you want to check the palpability of the arterial pulse. So for the, radial artery, I wanted to say. So that one, you just lift these two fingers and then be palpating the radial artery, whether you can palpate it. Okay, if you can't, it means that there is no arteriosclerosis. Okay, all right. Then the last thing is to check for the collapsibility of the pulse. So for the collapsibility, what you do is to ask your patient, because you are going to move the shoulder joint, the shoulder joint briskly. So you need to ask the patient whether the patient has any pain in that shoulder joint. Because remember that at the beginning of the exam, you assured the patient that the exercise is not going to be painful, although it may be uncomfortable. The patient has given you the trust. So you need to find out if the patient has any pain in the shoulder joint. So you ask the patient courteously, "Sir, please, do you have any pain in this shoulder joint?" He says no. Then what you do is you palpate. Okay? Then you take note of the volume there, the rate there. Then, after you are okay with it, then you briskly move the patient's arm, okay, against gravity. And then a collapsing pulse would hit you very hard. The volume will change to hit you very hard. And that also, like I said earlier, can indicate aortic regurgitation. Then after that, still on the pulse, you need to find out if the radial pulse on the left and the right are synchronous. Are they felt at the same time, or there is a delay between the left and the right? And so you are checking for radio-radial delay. Some books put it as radio-radial synchrony. So if there is radio-radial delay, it means that one is felt earlier than the other. If there is radio-radial synchrony, it means that they all felt at the same time. So it means that radio-radial synchrony can be reported as there is no radio-radial delay. So if you want to say that there is no radio-radial delay, you can report it as there is radio-radial synchrony. So radio-radial synchrony, no radio-radial delay. And then still on the pulse, after doing the radial synchrony, you want to do the radiofemoral synchrony. Okay, so you palpate the femoral pulse in the inguinal triangle. Okay, and make sure you feel it, and then you feel them at the same time. So let's demonstrate the radial delay. So you palpate the patient's radial pulse simultaneously. They can be felt at the same time. So in this patient, there is no radial delay, or you can say there is radial synchrony. Then radiofemoral synchrony. Radial delay may indicate that maybe there is an aortic dissection, or sometimes there is coarctation of the aorta at the arch of the aorta. Radial delay also may indicate coarctation of the aorta. So we need to take note of that. So once you are done with this, then the next thing is to check the patient's blood pressure. And here you quickly turn to your examiner. Say, please, at this point, I want to check the blood pressure of my patient. Usually you are not allowed to check it, but just make them understand that you realize or you recognize that checking of the blood pressure is part of the cardiovascular exam. And so you quickly turn to them. Say, please, at this point, I want to check the blood pressure of my patient. They tell you, carry on. However, the blood pressure of this patient, they give it to you, 130/80. Thank you, sir. Then we move on. So we are examining in this fashion. Once you get to the neck, in the neck, you want to note the character of the carotid pulse, and then whether or not there is a raised jugular venous pressure. And so, in order to see the raised jugular venous pressure, that is one reason why we prop the patient up to this angle. So to do that, you ask the patient to look to his left. You don't go and then when you get there, oh Papa, please, no, that is not courteous. You give a clear instruction. Sir, can you please look to your left? The patient does that. Once he does that, you see this muscle. This muscle is called the sternocleidomastoid muscle. The muscle which originates from the mastoid bone and then gets to the clavicle, okay? But at its insertion, it has two insertion points. One of them is to insert on the manubrum of the sternum, and the other is to insert on the clavicle, the medial end of the clavicle. So you see that this is the sternal insertion, and this is the clavicular insertion. Now, in between the two heads, you have the internal jugular vein running through. The external jugular vein runs in this direction. In this friend of mine, it is not very visible, but you know that the external jugular vein runs in this direction. Now, to find out if the patient has a raised JVP, the first thing is to look. And then there is something called showmanship. Tell the examiner that I'm looking. So you can turn on your pen torch, white light, and then look. Looking for pulsations. In this patient, I can't find any pulsation. Okay, but assuming I found a pulsation in that, or between the heads of the between the heads of the sternocleidomastoid, it could be a pulsation from the carotid artery or from the internal jugular vein. So how do I distinguish between them? So Oxford has a mnemonic called POLICE. P for palpability. If it is a vein, you should not be able to palpate the pulsations. Once you palpate, you feel the pulsations, it means it's from the artery. So that's one of the ways to distinguish between a venous pulsation in the neck and an arterial pulsation of the neck, or in the neck, I should say. Then, it may interest you that I will not go through all the mnemonics. But for the OSCE exam, I use the P and the O to distinguish between them. O for occludability. So when you occlude the pulsation at its base, if it's a vein, you will not see it again. But if it's the artery, you will see that still there is pulsations. Okay, so that is one way to distinguish, or those are two ways to distinguish between the pulsation from the internal jugular vein and the pulsation from the carotid artery. So, assuming you find that there is pulsations, okay, then you want to measure the height of the JVP. Okay, you want to measure the height of the JVP. And then the height of the JVP from the sternal angle of Louis. I would explain that. The sternal angle of Louis should not be more than 4 centimeters. If it is more than 4 centimeters, it means that the JVP is raised. The JVP is raised. And so let's assume that I found the pulsation here. So this is the height. Now this is the point where you need two rules. I'm sure that when we mentioned that you need two long rules in the cardiovascular exam, some of us were not sure what it is going to be used for. So to find the sternal angle of Louis, you need to palpate. This is the manubrium, okay? So you need to palpate the jugular notch or the suprasternal notch, and then rub your hand or your finger across, and then you find this ridge. Now this ridge is actually the angle of Louis. Then what you do is that so you put your rule there, and let's say that this is where the pulsation was. So you are measuring the height of the JVP, okay? Let's say it was here. So I'm going to measure the height of the JVP. Good. And then once I measure it, I'm reading on the vertical rule. So once I measure it, straight line, good. Once I measure it and it's more than 4 cm, then it is elevated. So a raised JVP can indicate a right-sided failure. Okay, so that's how to measure the JVP. It should not be more than 4 cm. Now, assuming I couldn't find this venous, I couldn't find the height of the JVP, I can elicit it. Okay, so I can do something we call hepatojugular reflux. So what I do is that I palpate deeply, okay, the patient's right hypochondrium to push some of the venous blood into the right atrium, so that if there is actually right-sided failure, you can see it in the internal jugular vein. But before I do that, the first thing I ask the patient is, sir, please, do you have any pain in your right hypochondriac region? No. But I wouldn't say right hypochondriac. Do you have any pain in this part of your abdomen? He says no. Okay, it means that I can do that. So I palpate deeply, and then with my pen touch, I'm looking for a raised JVP. Assuming the patient had pain in the right hypochondriac region, it doesn't mean that you won't carry on that exercise. You can do an abdominal jugular reflux instead of hepatojugular reflux. Is that okay? Alright. So we are done with measuring the JVP. Then, can you please? Then we can palpate the carotid pulse. We are looking for the character of the pulse. Sometimes the pulse character can give you a clue. For example, if there is aortic stenosis, the character is described as parvus etardus. That one you need to listen to the apex beat as well to see if there is a delay. Parvus means it is slow rising, and then tardus means it is late. And I think we explained that mechanism in our video on aortic stenosis. So you're just palpating the carotid pulse. Alright. So right after doing that, you move to the head of the patient. So you are climbing like that. Move to the head of the patient. So the head of the patient, you are looking for the fact whether the patient is pale or not pale, whether or not he's jaundiced or he's not jaundiced. So to examine for pallor, you give an instruction. Say, so I'm starting singly. Some people do singly. I'm starting with the right eye. Say, please, can you look into my palms upwards? So you are checking for pallor. You are comparing the, you see, the white part of the eye is called the conjunctiva, and then there is a fold which lies, or the white part of the eye, sorry, is called the sclera, and there's a transparent membrane which lies on the sclera. It is called the conjunctiva. The conjunctiva lines the sclera and then leaves the cornea. The cornea is that black, it's not that black thing, but it is demarcated by that black thing. That black thing is actually the iris. The cornea is a transparent membrane that also lies on top of the iris. But my point is that the conjunctiva does not cover the cornea, okay? And then after covering the sclera, it comes down to line the internal part of the eyelid. So we have the scleral conjunctiva and then the palpebral conjunctiva. The palpebral conjunctiva is a part of the conjunctiva that lines the eyelids, both the inferior and the superior. I don't know whether I'm communicating, but then you check for the pallor, the degree, the redness of the palpebral conjunctiva. Then this one doesn't look pale, does it? Then you do the same. Please, can you look up? Exactly, it doesn't look pale. Some people would like to do it simultaneously, but when I was in school, some of my professors hated that, so I think I am conversant with examining it singly. So then you check for scleral jaundice. You give an instruction. Sir, please, can you look into my palm? Checking for jaundice. The white there. Okay, is there jaundice? Sometimes you may have to use your pen touch. Good. Yes. That is called showmanship. There is no jaundice, isn't it? Then you can look at the malar region for what we call malar rash. Sorry, malar flash, not rash. Malar rash is for SLA, as it were. Malar flash, redness of the malar region. It may indicate chronic mitral stenosis. Then I come to the mouth. I want to check for oral hygiene. So I ask the patient, sir, please, can you show me your, can you open your mouth for me? So you are looking for oral hygiene first, okay? Then you want to check for central cyanosis. You don't check for the cyanosis on top of the tongue because what the patient has eaten may influence your judgment. So you ask the patient to lift his tongue up. Can you please lift your tongue up? You watch underneath the tongue, okay? The oral hygiene, to remember that sometimes in patients with infective endocarditis, the focus of the infections came from the mouth. So you need to also check that. Then, of course, you come to the chest. So the chest, the area of the heart, the area of the chest occupied by the heart is called the precordium. So you are going to examine the precordium. So the first thing you do is inspection. So inspection, you are looking for any chest wall deformities. Are there any chest wall deformities like pectus excavatum, okay, or pectus carinatum, like the chest of a pigeon? All right, we are looking for any surgical scars. For example, does the patient have? Yes, that is correct English. Does the patient have a lateral thoracostomy scar? If there is a scar here, probably the patient had a chest tube passed. For what reason? It may be because of a pleural effusion the patient had developed from congestive heart failure, or the patient may have a midline sternotomy scar. That scar is used for patients who are undergoing coronary artery bypass grafts, people who have myocardial infarction and all. Okay, so after you are done with that, you are looking for scarification marks. Then the next thing is to inspect the precordium. You are looking for a visible precordium, okay, a visible cardiac activity. So here you can turn on your pen touch and then look for visible cardiac activity. Sometimes if the patient has dextrocardia, you may not find the cardiac activity here, you may find it on the right, so you have to come and look for it. There is nothing like that. So on inspection, you didn't find any visible cardiac activity. So the next thing after inspection is to palpate for the apex beat. The apex beat is the most inferior, most lateral, maximal point of impulse. So to palpate the apex beat, I need to put the flat of my fingers here and then look for the point of maximal impulse. So for this patient, so I can't feel any pulsations on his axillary region, so I need to come medially. So for this patient, this is where his point of maximal impulse is. This is the apex of this patient. So then you need to determine the position of the apex. You found it, but what is the position? To determine the position, you need to identify our friend, the angle of review. So this is the ridge. You can see the ridge. I'm going over this ridge. So this is the ridge. So lateral to the ridge on the left is the second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space. Okay? And then this is the clavicle. It is in the mid-clavicular line. And so this patient's apex beat will be described as being in the left fifth intercostal space, mid-clavicular line. And that is the normal position of an apex beat. Now, assuming you didn't feel any apex beat here, you didn't feel it, then some conditions may explain why the apex beat was not felt. For example, if the patient is an obese patient, you may not feel the apex beat because of the increased fat tissue in the chest wall. Or if the patient has dextrocardia, right, the apex beat is now on the right, you may have to come and palpate, and that is the physical finding of dextrocardia, finding the apex beat on the right instead of the left. Or sometimes a patient with cardiac tamponade or cardiac tamponade, the fluid around the heart is so much that the heart's impulses cannot be felt. Okay, so you may not find the apex beat. But my point is, if you can't find the apex beat, try and then do it on the right, because for all you know, it may be a dextrocardia. Now, assuming you found the apex beat displaced, let's say in the safe intercostal space anterior arterial line, you want to know if the heart is truly enlarged or it is because of a mediastinal shift. Because a displaced apex beat can be because of a truly enlarged heart, or the heart is not enlarged, but there is a pathology in the contralateral hemithorax that is pushing the heart. So you are having a left mediastinal shift. So tracheal position is used to somewhat confirm that. In cardiovascular exam, you do not routinely look for tracheal position. But here, you quickly turn to your examiner. Sir, please, I would want to check the centrality of the trachea because the heart is displaced. I want to know whether it is because it is truly enlarged or because probably there is a mediastinal pathology that is shifting the heart to that position. Your examiner, for the sake of time, may tell you that, oh, there is nothing like that, so carry on. But if he wants to, go ahead. So to palpate for the trachea, your index finger, the right index finger, should be on the right sternal part of the clavicle, okay? And the left sternal part of the clavicle should also be touched by the ring finger. Then you ask the patient to, can you please extend your So this is the thyroid cartilage, the Adam's apple, what we call the Adam's apple, thyroid cartilage. And if you follow it down, you would see that the trachea follows it. And so in this patient, you see that there is equidistance, okay, between the middle and then this, the middle and that. So the trachea is not deviated. So my point is that if you have a displaced apex, it could be because of a mediastinal shift or a truly enlarged heart. Okay. Now, if you locate the apex, you need to describe its character. Is it tapping or is it diffuse? Okay, you need to describe that. Then right after that, still on palpation, you need to check for thrills and heaves. Okay. So you are checking for thrill in the mitral area, thrill in the tricuspid area, in the pulmonary area, okay, and then in the aortic area. A thrill is a palpable member. Then you want to check for right parasternal heave with the heel of your hand, the right hand. And then you need to bend a bit to see whether it is moving your hand up and down, okay? That's the right parasternal heave. It may indicate a right ventricular hypertrophy. We don't typically recurse in cardiovascular exams, so straight away you move to auscultation. Your stethoscope, the chest piece of the stethoscope is made up of the diaphragm and then the bell. The diaphragm has been designed to pick relatively high-pitched sounds, like the heart sounds. And then the bell has been designed to pick low-pitched sounds, like cardiac menace. But note that the bell can be converted into a diaphragm mistakenly by the examiner if he presses hard on whatever he's listening to. Then you've defeated the purpose of the bell. So the bell should just be on the patient's, just like once you press against it, you've converted into a diaphragm. So you need to listen for heart sounds. So for the heart sounds, the left field intercostal space mid-clavicular line is the mitral area. Then the fourth parasternal region on the left is the tricuspid area. And the second intercostal space on the left is the pulmonary area. Then adjacent that on the right is the aortic area. So you need to go through all those spaces. Okay. So you put it there. There is no right way of holding the stethoscope, but my superiors taught me to hold as though I'm holding the scissor form. Don't do this. It doesn't look nice. It's not even professional. Once you do this, you see it's nice and then it looks good. Okay, so you put it. Now, how do you tell whether the heart sounds you are listening, which of them is heart sound 1 and which of them is heart sound 2? To be able to, whenever you are auscultating the cardiac regions, you need to palpate the carotid pulse simultaneously, because that is the only point you can convince your examiner that you really heard heart sound 1. So you see, the sounds you hear, heart sounds 1 and 2, there are 2, right? So the first one is identified by the fact that it coincides with the pulsation in the carotid artery. Is that okay? So I put my stethoscope there and then I palpate it, listening for heart sounds. So the heart sound that coincides with the pulsation in the carotid artery is the heart sound 1. Yes, it is there. Then tricuspid area, I go through the same pulmonary area, and then aortic area. Okay. Then I can ask the patient to turn. Please lie on the left. Lie your whole body on the left. Looking for mitral reggae. Okay. Now, assuming I find a member, mitral reggae, it is a pansystolic member, I would have to follow it to the axilla. So I find the member here, then I have to follow its radiation. Okay. Sometimes the patient has to sit up. Please sit up. And then breathe in, out, and hold it. Looking for aortic orientation. Okay, please lie down. Then, of course, whilst listening, I need to be listening for other sounds like S3 gallop and then pericardial rub, etc. So once I'm done with listening to the heart sounds, I can quickly ask the patient to sit up and then listen for fine respiratory crackles at the base. So I'm listening to the auscultation, I'm auscultating the lung base. Can you breathe in, out, in, out. Again, in, out, in, out. Then I can check for sacral edema. Look at the patient's face and then check for sacral edema. Okay, so the patient doesn't have that. So good. Then, what I do now is to check for the peripheral pulses. Okay, so I begin with the brachial artery, because the cardiovascular. So this is the cardiac part. Now the vascular part. Okay, present and normal. Brachial artery on the left, present and normal. I come to the carotid artery. Is there present and normal? Carotid artery here. Then I come to the superficial temporal artery. Superficial temporal artery here. Then I come to the femoral artery. Femoral artery. I'm not an Ashanti, don't worry. Alright. Then popliteal artery. Can you please? You have any picture? Okay, so the thumb is here. Okay, then this is one of the very difficult arteries to palpate. Either there, femoral artery. Can you please place your leg? Thumbs here. And then these ones are palpating, femoral artery. Okay. Then I come to the posterior tibial artery, which runs behind the medial malleolus. Posterior tibial artery, it is there, present and normal. Posterior tibial artery, present and normal. And I come to the dorsalis pedis artery. Dorsalis pedis artery on the left. Then I end with palpation of the pedal edema. Okay, so I palpate, I press. Anytime I touch my patient, I press the skin against the medial malleolus. The patient has pedal edema. I'll have to continue upwards. So press the skin, look at my patient's face, press the skin against the shin of the, the tibia. Okay, patient, anytime you touch a patient, assume you have pedal edema, I continue and I get the upper limits of the pedal edema. But if it doesn't have pedal edema, I press it, I didn't see pedal edema, that is fine, I don't go further. Then after that, you thank your patient. Thank you for the exam. Please, I would like to present the findings, what I found on exam to my superiors. Because the patient confidentiality, you and the doctor-patient relationship, don't just thank him and then gossip about him. Please, I want to, when we give you the go ahead, you go to your examiner. So that is how to perform a cardiovascular exam. Thank you.